welcome everybody. Um, the speaker today is Dr. Andrew Shaw. He has a very modest introduction here. Father to Oliver, husband to April, PGY 5 in Psychiatry, who's recently passed his Royal College exams. And he's not staying here, unfortunately. He's heading up north to Sudbury for elective rotations. There's lots more to say about him, but let's hear his very important talk today. You can put your questions online or speak up. We can hear you. Thank you. Over to Andrew.
Hi, everybody. Thanks for coming today to my talk. This presentation has nothing to do with illness identity disorder. So if you came for that, I'm sorry to disappoint you. It's a different psychological concept that I've been interested since I was a PGY1 on my research block. And while I never did any research on this topic, I've been thinking about it over the years, noticing it in certain patients, and I'm very happy to share what I found in the literature with you today. So I have more volume? There's no mic. We looked. I'll try to project. I have no conflicts of interest to declare for this talk. I'm not being compensated, unfortunately. I have no financial stake in illness identity or how it's measured, and I chose this topic based on my own interest. I will say I am slightly under duress as this is a Royal College requirement, and I'm nearly there. So, learning objectives, I'm going to introduce the concept of illness identity, operationalize illness identity, and ask you to consider psychological factors in treatment outcomes for complex patients. This is a great book if you haven't heard of it. It was a New York Times bestseller for 9 straight months in 2019, written by James Clear, called Atomic Habits. And he was exploring, why people tend to be very good at sort of setting goals and some type of outcome that they want to achieve. Fewer people actually implement a process that works to try and make a behavior change. And he says fundamentally that true behavior change is identity change. So if you want to do something different, start thinking of yourself as someone who does that thing. And when it's in your identity, it becomes more effortless to do. Applying this to myself, we have Andrew Shaw's identity on one side here and non-identity items. So I enjoy a bowl of cereal much more than a plate of salad. Unfortunately, my identity swings that way. I like to run. I have all the gear. I think of myself that way. And going for a run is very easy for me to do. It's commensurate with how I think about myself. You'll never catch me cycling. That's not what I am. I'm not a cyclist. I like creative writing and watching the NFL, and you'll never catch me painting a canvas or watching baseball. I think this is a sort of societal moment. I would say we live in an age of identity. Particularly this month, you may have noticed a proliferation of flags that have nothing to do with statehood, but rather the identities of the citizens living in those societies. The phrase "I identify as" has become common parlance. So there's never been such an opportunity for self-expression, I don't think, in human history. Identity is at the core of that, perhaps fueled by social media. I first started thinking about the idea of illness identity before I knew it was a clinical term or that there was any research behind it, based on my interactions with a relative over the Christmas holidays. So I don't get to see this side of the family very often. This is kind of our one chance to catch up. We sort of make the rounds getting the life update from everybody. And this one relative invariably her life update is her concussion symptoms, how they've changed over time, what new treatment she's exploring, which specialists are involved. In fact, you couldn't really get an opportunity to reciprocate any kind of life update. It was so all-consuming for her. And she would repeat this conversation with everybody. And it was as if that was sort of the most interesting thing about her, is that she has a concussion and how this affects her life. So I started thinking how that might affect kind of treatment and what's sort of happening there on a psychological level. There's a related notion to illness, well, maybe just even the concept of identity, which is self-concept, which was first put forward by William James, who's one of the kind of founders of the field of psychology 1890. And he defined a self-concept as an ongoing awareness of one's innate physical and mental attributes and a recall of memories that are relevant to the current sense of self. And he acknowledged that self-concept can change over one's lifespan. So the way that we think about ourselves and the way we form our identity can change over time. I also want to invoke Rene Descartes. This is the individual who is most famous for his sort of mind-body dualism. He believed that the body and the mind were fundamentally consistent of different substances. And while he doesn't refer to the self at all, he did talk about the soul in a kind of related way. And he acknowledges that the body and the mind sort of interact and have a relationship with each other, and that things that affect the body can affect the mind and vice versa. So I'd ask you to think about the self, what you think the self is, and where it fits into this, whether you're a Cartesian dualist or not, where the self kind of fits into this equation. And you can imagine someone with a physical illness that affects the body, how the mind might compensate to that. And in the mental health field, if the mind is what is under attack, is that perhaps a closer relationship with the self than that with the body? This is another related concept to illness identity called illness self-concept. So they're using the terminology of William James here and applying it to illness. These are two American researchers, Ronald Friend and Robert Bennett. One is a professor of medicine and nursing, and the other is a psychologist. And they were interested to see if they could measure the concept or the construct of illness self-concept independently from other psychological factors, mainly optimism and self-esteem, which they thought might be confounding. So they wanted to try and isolate and measure illness self-concept unrelated to those other things. So they developed this scale that had sort of 3 subscales on it. So I'll just go through the subscales here. So directionality refers to whether the illness is driving the person's sense of self or whether the self is driving the illness. And I'll read some items from there. So some of the items are number 8, I feel consumed by my illness. Or number 12, I have preserved my sense of self in spite of my illness. The next subscale is pervasiveness, which is how much of one's sort of life space is dominated by illness. So some example items here. Number 1, my illness is with me most of the time. Number 14, I do many of the same things as healthy others despite my illness. And then the last subscale was illness self-consciousness, which is the extent to which a person is preoccupied with their illness. So the first one is very flat. I am preoccupied with my illness, or I only think of my illness when I have to. And I have some item correlations here. These correlations are how correlated each item is with the rest of the items in the subscale. So that's looking for kind of internal consistency there and sort of construct validity. As I mentioned, they were interested in measuring illness self-concept separate from self-esteem and optimism, which they included in the study. And in this study I'm going to talk about in a minute, it's the first time I came across the term engulfment, which was taken actually from mental health research in schizophrenia, where the illness or the sick role comes to dominate a person's self-concept. So this term engulfment means the person's identity has been so consumed by illness factors that that's sort of how they're thinking of themselves now. So Friend and Bennett studied a population of 200 adult patients with fibromyalgia. And this was a cross-sectional study. It was looking at correlations with various outcomes. So they had a symptom severity scale, a functional impairment scale, an overall life satisfaction scale, and they used the Beck Depression Inventory for depression, and they isolated out common symptoms of fibromyalgia from the depression score, like fatigue and poor sleep, etc. So here I've shown the correlations. You see, you can't see my cursor, but in the top right corner there is correlations between the illness self-concept scale and these various outcomes at 2 different time points. It's a delta R because what they did was they factored out the proportion of the correlation that was due to measures of self-esteem and optimism and patient education. So it's the change in the correlation when those things are factored out. And I don't know why they squared it, but they squared it, I guess, to not have the directionality included of the correlation, just the kind of magnitude of it. But in any case, you can kind of look at them there. And what they found was that the illness self-concept scale was strongly correlated with all outcomes except for depression. Depression was more closely associated with self-esteem and optimism and the patient's education level. But the other ones, which are very much related to symptom severity, function, satisfaction, were all highly correlated. The first time I came across the term illness identity proper was in this paper by Sharmaz in 1995. And he defined illness identity in the following way. So he says, impairment intrudes upon daily life and undermines the identity. Chronic illness disrupts the unity between body and self and forces identity changes. The idea being that the impacts on the body are inflexible. So if you have new disability or new limitations, that's not going to change. It's probably only going to get worse. And so the self has to kind of adapt to that. You can imagine if you were a cyclist before and you lose the ability to coordinate or walk or something, you're going to have to think of yourself in a different way. And this paper very much emphasized this idea of adaptation, which means altering the self to accommodate bodily losses and limitations. And he proposes that patients can adapt in an adaptive way or a maladaptive way, and that outcomes would be disparate between the two. We're more familiar maybe with the idea of the sick role in psychiatry. We talk about this a lot. I would say that is sort of the behaviors that one adopts that are commensurate with their sort of illness identity, perhaps. And this idea of taking refuge in illness. So if someone sort of surrenders to their illness, their limitations and such, that would be maybe a type of adaptation to illness that they're no longer struggling with it. It's sort of taken over their sense of self. I like this quote here. He says, when forming an illness identity, it's the self versus the body, struggle versus surrender, objective reality versus subjective experience, and bodily control versus loss of function. You can see there's sort of a lot of tension and almost like a battle occurring there in the person. So next, my journey took me to Belgium when I was exploring this concept of illness identity. I'm going to try to say this, KU Leuven. Maybe that's how you say it, I don't know. But when I went to the website to try and track down some researchers that were interested in illness identity, the website was all in Belgian. I had to use Google Translate to try and find somebody that I could contact. And I eventually found this person, Dr. Lien Orris, who's a clinical psychologist who writes her papers in English and was responsive to my emails. And you can see her publications here. She's looked at different populations with different chronic illnesses exploring this topic, and actually developed a scale called the Illness Identity Questionnaire that I was interested in, and she sent it to me. She was heavily influenced by Erik Erikson's psychosocial theory of identity. I'm so tired of talking about this. It's been beaten into me for Royal College exam, the ages, the stages, conflict, the virtues. But the only one I have to talk about today is the sort of adolescent stage from 12 to 18, where this is when people's identity is forming. And it either forms coherently or they get kind of a role confusion state. And you're hoping that they emerge from this developmental stage with the virtue of fidelity, so that they feel like they know themselves, they have a complete sense of self, and they go out into the world as adults. So just to remind you, Erik Erikson says, the degree to which an individual integrates different self-assets into a coherent sense of self, and a coherent sense of self translates into daily life and guides our choices and our values. A coherent sense of self gives rise to feeling of continuity, sameness, that contributes to psychological well-being. This is the kind of seminal paper on the topic where Orris and her colleagues explain what they mean by illness identity, and they introduce the Illness Identity Questionnaire. So if anyone's interested in that, I have references at the end. So they developed this questionnaire, and they found that they applying it to different samples, they were able to identify 4 distinct identity states that can form when someone has a chronic illness. 2 of these are generally thought of as adaptive, so acceptance and enrichment, and 2 are thought of as more sort of maladaptive, so engulfment, a term we've heard before, and rejection. So engulfment is a patient whose identity has been overwhelmed by their illness, and it's the thing they talk about at cocktail parties, for example. It's the most interesting thing about themselves. Sorry, didn't mean to go forward there. Rejection is the person who denies they have an illness at all and tends to downplay its impacts. And this identity state is most closely associated with poor treatment adherence. Of course, you're not going to take a treatment for an illness that you don't believe that you have. Acceptance is probably where the majority of patients land, I would say. This is when the disease is a part of their identity, but not the whole thing. And they tend to remain quite functional despite new disease limitations. And then the enrichment state is kind of the holy grail, top of Maslow's hierarchy of needs. This is like a self-actualized, glorious state where disease empowers identity change. So an example would be someone is diagnosed with breast cancer. Instead of being crushed by that realization, they start wearing pink ribbons. They start going to charity events. They're doing runs, raising money and awareness, etc. So people can experience identity enrichment through illness experience, and I like that this paper acknowledges that. So here's the thing that I really wanted, which is the illness identity questionnaire. Basically, there are 4 subscales which represent each of the different illness identity states that were proposed. They did factor analysis looking for both discriminant and internal validity between subscales, and they wanted to make sure that it would reliably sort patients into the same category and not more than one. So you couldn't have someone who has both a rejecting illness identity state and an accepting identity state. That wouldn't make any sense. And it was a 5-point Likert scale on each item, which gives you some kind of quantifiable measure there. So I'll just read a couple items because I think it's really interesting. So number 2 is, I'd rather not think of my illness, from 1 to 5. Number 7, my illness is a part of who I am. Number 13, I am preoccupied with my illness. Number 15, my illness completely consumes me. So depending on how you score, you would be sorted into one of these illness identity states. I'm going to get into that more. These are the different subscales. I'll just read a couple. So for the engulfment items, you have something like, my diabetes prevents me from doing what I would really like to do. This version here has been adapted to be diabetes specific. Rejection items, I refuse to see my diabetes as a part of myself. Acceptance items, my diabetes simply belongs to me as a person. And enrichment items, because of my diabetes, I know what I want out of my life. That's someone who's experiencing sort of self-actualization. I'm going to go through a bunch of studies by Oris and her colleagues here. All of them are cross-sectional in design, so I just want to remind everybody that it's very difficult to infer causation. So is more severe illness causing a certain illness identity, or is an illness identity causing a severe illness? We're not going to be able to tell from these studies. They're interesting nonetheless. And all of the outcome measures were all various self-report scales, which come with certain trappings that we all kind of know about, like recall bias, social desirability bias, sampling bias, ordering effects, all of these things. So just keep that in mind as we're going through them, just that you don't want to overstate what's being claimed here. And although, the scale can be adapted to various physical illnesses, I didn't come across any reason why it couldn't apply to mental health as well. It was developed for a chronic illness with daily intrusion into the patient's life, and the various items are very non-specific. So I would be interested to see it kind of used in mental health populations. So they validated the scale first on a population of type 1 people with type 1 diabetes, published in 2016. They looked at 575 adolescents and young adults. That was to try and place them squarely in Erik Erikson's sort of identity formation developmental stage. And diabetes was chosen for its chronicity and integration into the patient's daily life. Right? You're having to measure your glucose every day. You're having to give yourself insulin, maybe take medication, right? And they found that they were able to reliably, sorry, I'm all over the place here. They were reliably able to sort this sample into these 4 subscales. So people would either develop a maladaptive way of modifying their identity to the illness or an adaptive way in one of these kind of 4 groups. And their outcome measures in this study were 2 measures of psychological functioning, mainly depressive symptoms and life satisfaction. And then they looked at some diabetes-specific functioning, so whether the patient encountered any diabetes complications, whether they had good or poor treatment adherence, and they also measured their hemoglobin A1C level. And what they found was that in the enrichment group and the acceptance group, they had higher levels of psychological functioning, so lower levels of depression and higher levels of satisfaction with life. And the acceptance group also had better diabetes outcomes, which is interesting. The rejection group had the poorest treatment adherence. You're going to hear me repeat that over and over again. And commensurate higher hemoglobin A1C levels. And the engulfment group is where we saw the real impairment, both in terms of psychological functioning and diabetes outcomes. They next looked at 2 different populations, so 400 adults with congenital heart disease and 241 adults with either lupus or systemic sclerosis. Again, these are chronic diseases with daily intrusion into the patient's life. And again, they were able to reliably sort participants into one of these 4 illness identity groups. Interestingly, there were no sex differences in the distribution among the different identity states. So men and women were pretty equal in all the groups, or not statistically significant. And older patients seemed to sort more into the rejection group. I wasn't sure what to make of that, only that I have examples of older people in my life who tend to be more maybe suspicious of doctors or healthcare, or kind of want to just do it on their own kind of thing. But you can have your own thoughts about that. We see again, so the acceptance group had the lowest levels of depression and anxiety and the lower reported sort of symptom severity. The engulfment group had higher on both. Rejection wasn't related to mental health differences. And that might be because, if you don't acknowledge the illness in the first place, denial is a very powerful defense mechanism, and you're not going to sort of correlate it with any kind of mental health problems. And the enrichment group, this is an interesting finding, had actually more reported physical symptoms, but no mental health differences. And what these studies consistently find is that actually patients with more severe illness can kind of go one of 2 ways. They can either go onto opposite ends of the spectrum. They can either become engulfed by the severity of the disease, or they can become enriched by it. And that the outcomes are very different in terms of which way the patient tends to go. This is a closer look at the congenital heart disease group. So in the engulfed group, they had higher levels of healthcare seeking and hospitalization and lower functioning overall. The enrichment group had higher functioning despite higher reported symptom severity. And then just to talk again about rejection, poor treatment adherence, and actually more time off work, interestingly, for the disease they don't have. The last group they looked at was a refractory epilepsy population. So this was 358 adults aged 18 to 40, so a slightly older group. And they had to have no cognitive impairment because this is all these self-report questionnaires you need to be intact. So they gave them the illness identity questionnaire, a health-related quality of life scale, and a Liverpool seizure severity scale, which looks at frequency and severity of seizures. And then for some reason in the discussion, they didn't comment on the seizure severity scale at all. So I'm not sure if they just didn't find anything or if it was unrelated. But the quality of life measure was again kind of predictable, right? You have higher levels of quality of life in the enrichment group and the acceptance group, unrelated in the rejection group, and lower in the engulfment group, as well as more reported medication side effects in the engulfment group. So we're seeing a trend no matter which population this questionnaire is applied to. I wanted to include one paper that had to do with mental illness, since this is a group of psychiatrists I'm speaking to. So there's this paper from 2010, published in the American Journal of Psychiatric Rehabilitation by Janos and his colleagues. It's a bit of a convoluted paper to go through, lots of jargon, and a bit of a different definition of illness identity than I was using with ORIS. So basically, they seem to be basically using the concept of illness identity as almost synonymous with internalized stigma, which is something that we talk about in mental health. So this idea that someone with a very strong illness identity, who's maybe more skewing toward engulfment, is suffering from high degrees of internalized stigma, is what they were sort of saying. And they did kind of try to relate illness identity to hope and self-esteem, engagement in rehab, vocational outcomes, symptom severity, and social engagement, and how all of these things relate to suicide risk, making the point that this is relevant in terms of even very severe outcomes. And so this is just furthering that point. They sort of seem to say that someone with an engulfed illness identity has basically internalized stigma. And this is maybe familiar to us. I think we've kind of acknowledged that our diagnoses can sometimes maybe engulf somebody in an illness identity. We've changed our language around certain diagnoses, from someone who's a schizophrenic to a person with schizophrenia, kind of putting the person first. A borderline patient is a person who has difficulty regulating their emotions, ways that are kind of putting the person first and trying not to, refer to them as their illness. And they comment in here that illness identity may produce roadblocks to treatment in many persons with severe mental illness. What I did like about this paper is they had some treatment suggestions on offer. So they thought that viewing illness identity through a CBT lens, you might think that perhaps an illness identity is made from core beliefs or schemas about the self, and that maybe these could be challenged through cognitive restructuring. And they kind of view self-stigma as a kind of cognitive distortion that, again, maybe the 5-part model thought record could help a patient sort of change over time. They also thought narrative therapy could be helpful, which makes sense to me. So this is trying to reposition the patient as the protagonist with an active role in their story, as opposed to kind of consumed by their illness and kind of passively responding to new symptoms and complications, etc. And narrative therapy is very big on themes of empowerment and agency over helplessness and surrender. You remember in that Sharma's paper, there's this struggle between mind and body when someone gets sick, and you don't want them to surrender. You want them to kind of struggle against it or maintain other self-assets. To my great fortune, there was just a systematic review of the topic of illness identity published by associated psychologists at California State University. In total, they included 12 peer-reviewed papers with quantitative data. All of these are chronic illness populations, and they included all of the ORIS papers that I already went over. So all of those were included in this review. And they made some key findings and had some statements to go with them. So they say that the relationship between illness identity and treatment adherence has moderate evidence in favor. The relationship between illness identity and negative health outcomes has moderate evidence. And the relationship between engulfment and enrichment is related to illness severity, and there was consistent evidence between populations there. So that's what I was talking about before, that patients with more severe or complicated illness can kind of go one of two ways. Into an engulfment identity state or an enriched, glorious state. And they make this comment at the end of the paper that routine illness identity screening may allow for identification of individuals who would benefit from increased support, whether that's CBT or narrative therapy, I think they also proposed acceptance and commitment therapy as something that could be helpful. Then they have this great sort of graph here. They sort of split the illness identities into non-integrative and integrative based on how much the chronic illness is subsuming the self. So on the sort of less adaptive side, lower functioning, you have on the left of the slide here, this is like a rejection state where the chronic illness is completely outside the person's sense of self. On the right, you have an engulfed state where the chronic illness is dominating the self except for this little sliver here. And that a state of integration, which is more adaptive and associated with higher levels of functioning, is when some of the illness is incorporated into the person's self, but doesn't engulf it. So from those 12 papers, they made this chart, which can look kind of scary at first, but I'll break it down for you. So the size of the circle has to do with the strength of the evidence. So the bigger the circle, the stronger the level of evidence. And I've highlighted the rows that are most interesting to me here. So with the treatment adherence piece, we saw from those ORIS papers that it's negatively associated with a rejection identity state or an engulfment state. So these are kind of more maladaptive illness identities. And then in terms of anxiety and depression, both engulfment, so acceptance here is associated with sort of less anxiety and depression here, and then the rejection is more associated with higher levels of anxiety and depression as well. Yeah. In terms of quality of life, I've kind of already gone over that. So coming back to my relative that I see once a year and kind of what's happening with her, I kind of wonder now whether or not this is a case of engulfment. And I wonder, would symptom resolution for her translate to her sort of losing her identity? If you're asking her to get better, are you asking her to kind of give up a piece of herself? Would you be willing to do that if it was something that you really cared about? What will they talk about? What's the new life update? What's the thing that's most important in their lives? And I would wonder what you think. Does this realization provoke more empathy? Any kind of negative countertransference? Does it, maybe lead to more stigma if you identify patients as engulfed? Or does it just kind of change your approach a bit if you were able to identify that correctly? So I'll just conclude with some provoking thoughts here. So, could the illness identity questionnaire be practically implemented as a screening tool or maybe reserved for more complex or refractory cases? Does identifying an illness or a patient as engulfed provoke empathy or promote stigma? Does diagnostic labeling promote engulfment, right? We've all kind of I've seen it in real time when you tell a patient you think they have a particular diagnosis, you can almost see it in their eyes, how they're changing the way they think of themselves. It starts to explain everything that's ever happened to them. And no doubt they go forward with that new identity in mind. Does symptom remission mean identity dissolution for some patients? Did this presentation bring a certain patient to mind, perhaps a friend or a relative? And is the impact of mental illness on identity greater than for physical illness? What do you think? So I would invite anyone who wants to ask a question to do so. I'll do my best to answer, and we'll see if we can hear you on Zoom. And if you don't get a response, then put it in the chat and I'll kind of look at it now. I'm getting some virtual applause on Zoom, but none in the room. So. Thank you.
Trying to give time for discussion on this fascinating subject. We got about 30 people and 2 groups online.
Oh, nice. Good.
CLA group and the PR.
Let me check the chat here. There's one. Oh, that's just Jennifer.
Looks like there's a couple hands
Yeah,
up.
my academic advisor. Go ahead. Just one sec. Just one sec. I'm going to repeat the question once she says it for the Zoom people. Yeah. Okay, go ahead.
Very nicely put together. I like very much that challenges our beliefs. And one of your questions was if your presentation brings the case to our mind, and I kept thinking about her all the time. So it's a patient with somatization disorder, where the illness, the physical illness identity, really fills in her personality needs. And she was sick 5 years ago. She got better, but she holds on it. So how do we sort out her acceptance? How can we help her diminish the fusion between her identity and the symptoms of the illness, which she needs so much, in order to go up there on the core, bring her to a more functioning level?
Yeah. So Dr. Marin shared a case about an somatization disorder, a patient who, despite kind of improving, maybe has kind of an engulfed illness identity. And her question was, how can we move her into a different illness identity state? I'll just say I don't think the answer is sertraline. And there wasn't much in the papers around how to do that, which is something that was kind of missing. There's that paper by Janos, the American researchers, that says, here's some treatment suggestions, in terms of CBT, seeing it through that lens. Can you challenge these core beliefs or schemas? Is narrative therapy something that you have access to in the community, where they tell a different story about themselves, so that the story isn't, I got this illness and then I had all these symptoms and then I just could never overcome it. We want more of a hero's journey, perhaps. So that's maybe all I can say based on the papers that I reviewed. The answer must lie in the psychotherapy realm, because it's a very psychological concept. So yeah, that's all I got on that one. I wonder, even talking to the patient, like I've never done this, but I wonder talking to them about like how they think of themselves, and is that a difficult question, and how much does the illness intrude? Perhaps sliding the illness identity questionnaire across the table, so you have some numbers to go with it, and say, look, this is showing a bit of an engulfment, and then maybe that's some light bulbs go off. I don't know. That's all I've got to say about that. We have Dr. Flynn.
Well, you said you don't have the answer. And let me start by saying thank you for this talk. It was really, really well done. But you said you don't have the answer, but you actually mentioned acceptance and commitment to her. Mm-hmm. Tell us about that.
I don't know it very well. I had to know a bit about it for the Royal College. I never got asked about it. I've never done it before. So it probably has something to do with balancing this like accepting of who you are and your identity with making a commitment to try and change. That's me just kind of reading into the name. It's also very like a DBT kind of theme of like the principle of dialectics being balancing acceptance and validation and need for change and that. But that's all I got on that. That's my Royal College answer.
But maybe you should study ACT and then come back and tell us next year.
Okay, yeah. I'll Zoom from Sudbury, yeah. I'm going to check the chat here just to make sure I'm not missing anybody. Sorry, the question from Dr. Flynn was about acceptance and commitment therapy as a possible treatment. Sorry. And you heard my answer, I suppose. Oh. Okay, Dr. Chu, you can try to speak it. We'll see if we can hear you.
Can you hear me?
Yep.
Hi, that was really great. Thank you so much, Andrew. I was really fascinated because, the area of neuropsychiatry, of course, falls right between this dual bit of the mind and the body split. And I think we're moving away from that Descartes thinking of there being a split. or we're trying to. But the problem is that because this idea is so entrenched in our thinking that it's very hard to get our medical colleagues to move away from that. And I believe that's why sometimes they kind of disregard or have a lower regard for mental health. And I think it's really important to think about those people who fall between the gaps, who have these functional disorders. They have physical symptoms. We can't deny that. They are real physical symptoms. But the root cause of this is, functional. There's no organic basis for their condition. So I just wondered, with the readings that you've done and the research with which you have examined and studied, what's the kind of directionality in which we should move to sort of embrace a more holistic health care for this type of patient?
Oh, thank you for the question. Yeah, I mean, for me, I guess there's a certain type of patient that I start to think about illness identity for. It's usually somebody who is maybe, I guess, like the systematic review mentions that it might be worth screening broadly for illness identity, and I'm not sure I would do that. I think I would reserve it for somebody who's maybe not responding to conventional treatments. I like thinking about psychological factors that contribute to illness. If someone seems like they're sort of, this is kind of who they are, and this is the most interesting thing, the thing they would talk about at cocktail parties, right, is their illness, their symptoms, etc. I'd be curious with some of my patients to use the illness identity questionnaire and just see if that's a factor, and see if I could have that conversation with them without it coming across as dismissing or stigmatizing or something to that effect. I think the vast majority of patients probably sort into the acceptance category, but for those that don't, we're just plowing them with meds or doing therapies that aren't addressing. If someone's not willing to give up their identity, which none of us would be, if you asked me to stop writing or something, I would never do that, right? So if you're thinking about your illness as part of yourself, why would you ever give that up? And to be aware that you might be asking your patient to do that seems interesting to me. Does that answer your question, or was that just me pontificating?
No, that's really great, and I'm curious because a lot of these patients I see just fall between that gap, and asking them what they think is wrong with them, I think can be really telling, which is kind of what this is almost getting at.
Okay, Dr. Ian Runday has his hand up, so go ahead.
Thank you very much, Andrew. That was really, really good. And if that's your valedictory presentation, it's well worth it. It was engaging. A few comments and questions. It was certainly very thought-provoking. I'll give a bit of personal narrative to go with it as well. And introspecting as a psychiatrist who has embraced an illness identity with long COVID, it's interesting how much we validate, how much do we invalidate, and by either invalidating people's illness identities or negating it, could we be potentially doing harm? Are there therapeutic benefits in groups coming together? Perhaps, for instance, people with an illness condition who support themselves, like MS support group and so on. So there's that as a reflection, and you've left me with a lot to reflect on. Quick comment on the tool that was used that had the questions, my diabetes, and this is more linguistic. By the time every single question has the my linked with it, it's nearly inviting the person responding to the questions to own the my is the self and the disorder. So I just wonder whether even just the phraseology of the tool itself, albeit well meant, could be reinforcing, bringing the illness and the self more and more together. My diabetes, my depression, my, with that. Um, so that's another two quick ones, and then I'll try to. A reflection also is illness identity and intersections. So illness identity and migration. A person who may have lost sight and have an illness identity around their blindness and move into another part of the world, or an illness identity as it evolves with age. And so on, or gender, and the sort of intersectionality that may occur with that. And final bit, this is a quadruple decker comments question bit, is also how the names of our clinics may contribute to illness identity, unwittingly so. So if you're referring someone to a personality disorder service and making a distinction between that and referring someone to Heads Up, which will be an early psychosis program and so on. And could we, by naming our clinics, also facilitate or harm illness identity? Great presentation, amazing validatory work. Thank you. Great, thank you.
Thanks for those comments. You got me thinking about one other thing. Someone, I think it was Dr. Flynn's question maybe, or someone was saying, when would you maybe suspect that someone has one of these more maladaptive illness identity states? There's a type of patient that I meet that seems to have been over therapized, where they are almost speaking about themselves in clinical terms, using defense mechanisms, or that's me using black and white, that's me projecting, that's me doing this and that, right? And while that can be useful, it could just be that they've gained insight into those things. I think that could take the form of kind of an illness identity capture. If you're thinking of yourself as like a clinical case all the time, to the exclusion of everything else, that could maybe be someone I slide the illness identity questionnaire across the table to in a polite and non-stigmatizing way. Anyone else have a question? Oh, we have Dr. Jokic.
Okay, thank you so much. Andrew, this was really thought-provoking. I think that one thing we have to remember when we talk about patients with chronic illnesses and the role of mental health professionals, the one thing that is most important is developing and maintaining a trusting relationship. So the first contact with all these people, whatever stage they are in, is that the referral to a psychiatrist or a psychologist is going to be punitive. Like, why are they sending me? They think it's in my head. So developing that relationship from the beginning is difficult. The other thing, and now I'm talking from my own experience with treatment-resistant mood disorders, and many of them have either somatoform somatization problems or diagnoses, is that you really have to focus on and know about the medical problem that you're dealing and show your knowledge to the patient and show them that you know where they are at. And then comes this other part. Many people with somatization are in the left, but they don't know what's wrong with them because they have all these symptoms and everything is normal. And this is the question, so what do I do then? Well, we are all trained to say, well, your symptoms are real and we're validating them, but you have to kind of go beyond that. And usually what I would say is at this time, it is not clear. But maybe as we work towards finding an answer, these are some of the things that we can do in the interim. It seems you confused all these physicians and they don't really know what's wrong with you. But let's try working on this. The referral for psychotherapy that comes early is not going to go anywhere.
Right.
And just sort of the last comment, I really like the concept of the narrative therapy and even asking these people of sort of, imagine you're sitting in a movie theater and you are watching your life unfold. And that will bring a lot of information as you're getting to know the patient, because immediately, and of course this is for psychiatrists, if you say, well, you're gonna do CBT, they're gonna say like, no, no way am I going to see a therapist. I'm in pain and
Right.
right. So anyway, so that, just a few comments there.
So Dr. Jokic's comment was on being referred to a psychiatrist in the first place for patients with debilitating physical symptoms sends a certain message, and then saying you need to be very knowledgeable about the physical illness that you're treating so that that's not being dismissive. And then a final comment on what did you say the last part? I forgot. I kept trying to hold through, my working memory is only so big. What was the last part?
This is Royal College exam.
Yeah. Okay. Anyone else in the chat? It's too bad Dr. Cabrera is not here. I was looking forward to the lashing that I was going to get. I think that's it. Let's Dr.
I don't have a comment on this. I have a comment to make, Andrew. This is such a fascinating topic. It could be very similar to the Ross grief stage. It's like a person could go through different stages of this.
Right.
And first time you disclose a serious chronic diagnosis to anyone, first thought is no, it can't be me.
Right.
Rejection.
Right.
And you hope the next stage, you feel very overwhelmed as you start to take it in.
Right.
And that's like anger, state
Yeah.
of anger.
Yeah.
And then you move on to acceptance.
No, that's a really good point. That William James's contribution there, saying that self-concept changes over time. It's not fixed. I didn't always think of myself in certain ways. I do now, etc. And I think I like that actually. I didn't think about that, but yeah, there's like an illness progression of identities as things go on, and hopefully they end up at enrichment and not engulfed.
And a person could move on to, I'm going to fight it.
Yeah, right. Yeah, totally. I didn't come across any studies that was measuring illness identity at different time points. That would be interesting. Like patients that are very late in disease progression versus early, new diagnosis, etc., to see how it changes. I don't think any of those papers exist. Yeah. That'd be cool. I think we have Dr. Rivera is on screen here. Is she trying to say something or?
Yeah. Can you hear me?
Yep.
Oh, good. Maybe I should say it rather than try to type it. I just wonder, Andrew, if you're going to do a study on this.
That was my goal.
You really need to.
That was my goal in first year, and I actually had a supervisor. He was a family doctor who works for the military with PTSD, and that was going to be my population. And then my research block ended, and I got busy on Burr 4, and then it just fell through, and then I never came back to it. So in Sudbury, if I get on with the team there, there'll be research requirements. And since I've done the preliminary research, I'm interested in this topic. I would like to do something with illness identity and maybe become that guy in my own identity. I'm the illness identity guy.
And it would be very interesting to see it just as they did it with various physical illnesses, if you could do it with various diagnostic categories, because it certainly is a major issue with people who are referred to our program. And it really depends, for instance, where they're coming from. Like I have a person now who's been in and out of hospital for depression and anxiety for 25 years. And he really is very smart and should be able to do the work and is for a while, but he can hardly tolerate letting go of the idea of when I get a little bit too upset and stirred up, it means my depression is bad and my anxiety is bad and I have to go to the hospital and I need more medication. And it's hard for him to let it go, and yet he really wants to, because it's not just like getting rid of his identity. He's lost his identity. He's a very smart guy who had a very high functioning job before he bought into, I am someone with a mental illness, and he sees other people working on these issues, and you can see the ambivalence. It's extremely interesting to see that. I'd love, for instance, if you were doing it, to do some of the patients that we have, as well as people suffering from schizophrenia. That would be a different expression, you know.
Oh,
So I
yeah.
encourage you to become this guy.
Well, maybe you've already taken step, like at the service that you run there. Like, I remember we don't really use diagnostic labels so much. We just talk about problems that people are having. So maybe that's already kind of recognizing this phenomenon, is that if you tell somebody that the problem is in their personality, is that not you saying that it's a problem with the self? And then how does their self not kind of wrap around that? And depending on what you think about, you know, the self versus personality versus the mind or whatever, maybe that makes sense or not. But yeah.
Yeah, I think it's a big philosophical basis of the work that we do, both not only the staff and faculty, but the patients too. You know, if somebody says, "Oh, I didn't come yesterday to program because my depression was very bad," and you'll hear this titter go through the group, and someone will roll their eyes. It's like, "Oh yeah, you broke your leg," you know. So I think I think that would be a very interesting frame of reference that we haven't used enough, and maybe that could be part of your career. Anyway, I enjoyed your presentation, and I encourage you to expand it.
Thanks, Dr. Rivera. I appreciate that. This will be the last question here because we have time, but Dr. Al Musawi says, how does identity relate to premorbid functioning, including social involvement? And then any information available on this. So this is, how does identity, not illness identity, so to premorbid functioning. So this is not an illness identity, but the identity the person has before they get sick. And how does it relate to functioning, including social involvement? I guess people, like, when they identify a certain way, whether it's with an activity or a sport or a sexuality or something, they tend to congregate into groups of people who also identify as such. So I would say that's how people socialize, is based on common identity characteristics. Not all the time, but to some extent anyway. And we know that that's good for mental health. I think people need that sense of community, that sameness, that belonging. There's probably tons of literature on that. Like, I don't have anything on hand, but yeah. Okay, I think we'll end there. Thanks everybody for coming to my talk, and thank you, Dr. Prost, for supervising me and for all the conversations that we had on the topic that were quite interesting. Thank you.
Okay, thank you. Congratulations.